So, after studying this module, you should be able to understand dementia and its causes, differentiate between normal and dementia related memory problems, understand clinical picture and causal factors in Alzheimer's disease, evaluate the different treatment methods, and recognize other types of dementia. The DSM-4-TR presents the diagnostic coding of the various neuropsychological disorders in different and somewhat inconsistent manner. The disorders included in the section of cognitive disorders are delirium, dementia, amnesic disorders and cognitive disorders not otherwise specified. Most of the coding depends on the cause of the cognitive problem being presented. Age is a major risk factor in most of the neurodegenerative diseases, including mild cognitive impairment, Alzheimer's disease, cerebrovascular disease and Parkinson's disease. In this section, the focus will be on dementia, Alzheimer's with late onset and vascular dementia, as both of these are related to advancing age. Let us first come to know what is dementia. The term dementia originates from Latin and literally means without mind. It implies serious loss of cognitive ability and is characterized by a decline from a previously attained level of functioning. Dementia is a progressive global decline of cognitive functioning without impairment of consciousness. The decline in cognitive functioning is more than is expected to be the result of normal aging process. The onset of dementia is typically quite gradual. However, even in the early stages, memory is usually affected, especially memory for recent events. As the disorder progresses, marked deficits in abstract thinking, difficulty in acquisition of new knowledge, problems with visuospatial orientation and motor control, and difficulties with problem solving can be seen. It is also often accompanied by impairment in emotional control and in moral and ethical sensitivities. Hence, we can say that dementia is a syndrome rather than a specific disease. It may be progressive or static, but is more often the former. Sometimes dementia is reversible, as if it has the underlying cause that can be treated or reversed, like a vitamin deficiency, but dementia caused due to aging usually has a poor prognosis and needs a different form of management. It therefore becomes important to be able to distinguish between cognitive impairment due to normal outcome of aging and that due to dementia. The table highlights the differences between normal and dementia related memory changes. For example, in normal related memory changes, the individual is able to function independently and pursue normal activities despite occasional memory lapses. However, the symptoms that may indicate dementia are difficulty in performing simple tasks like paying bills, dressing appropriately, washing up, forgetting how to do things that the person may have done many times. Another difference could be that in normal aging process, the individual is able to recall and describe incidents of forgetfulness. However, in dementia, the individual is unable to recall or describe specific instances where memory loss is caused. Other changes in normal memory problems are that the individual may pause to remember directions but doesn't get lost in familiar places. However, in dementia, the individual gets lost or disoriented even in familiar places and has difficulty following directions. Other changes in memory related problems which are normal are there is occasional difficulty in finding the right word, but there is no trouble holding a normal conversation. However, symptoms that indicate dementia could be that words are frequently forgotten, misused or garbled, repeats phrases and stories in the same conversation. Other normal related memory problems could be that judgment and decision making ability is the same as always. However, in dementia there is trouble making choices. The individual may show poor judgment or behave in socially inappropriate ways. Let us come to know what is the epidemiology of this disorder. First of all, it is very rare before 55 years of age. Second, there is 5 to 10% precedence in the age of 65 and above. There is 20% of cases of dementia in the age of 80 and above, and there is 80% of cases in age 100 and above. Let us now know what is the DSM-4 TR criteria for dementia. The first point includes that the development of multiple cognitive deficits is manifested by both number 1, memory impairment, and number 2, one or more of the following cognitive disturbances. These disturbances are A. Aphasia, that is language disturbance. B. Apraxia, that is impaired ability to carry out our motor tasks despite having the motor ability to do so. C. Agnesia, that is failure to recognize and identify objects despite intact sensory functions. D. Disturbance in executive functioning, that is planning, organizing, sequencing and abstract thinking. These symptoms must be present for at least 6 months for a diagnosis to be made. Cognitive dysfunction of shorter duration is called as delirium. Besides the problem of memory, dementia reduces the ability to learn, reason, retain or recall past experience, and there is also a loss of pattern of thoughts, feelings and activities. Other mental and behavioral problems also often affect people who have dementia and may influence the quality of life, caregivers' reactions and the need for institutionalization. As dementia worsens, individuals may neglect themselves. They may also become uninhibited and inconsistent. Their behavior may become disorganized and or inappropriate. Some people become restless and wander about day and night. When people with dementia are put in circumstances beyond their abilities, there may be a sudden change to tears or anger, that is a catastrophic reaction. In the later stages of the condition, the patient may be disoriented in time, that is not knowing the day, week or even year, in place, that is not knowing where they are, and in person, that is not knowing who they are or the others around them. A common symptom of dementia is for dementia sufferers to deny that relatives, even relatives in their own immediate family, are their own relatives. Let us now know what are the causes of dementia. Dementia that begins gradually and worsens progressively over several years is usually caused by neurodegenerative disease, that is, by conditions that affect only or primarily the neurons of the brain and cause gradual but irreversible loss of function of these cells. Less commonly, a non-degenerative condition may have secondary effects on brain cells, which may or may not be reversible if the condition is treated. Causes of dementia depends on the age at which the symptoms begin. In the elderly population, usually defined as being over 65 years of age, a large majority of dementia cases are caused by Alzheimer's disease, vascular dementia or both. Hypothyroidism sometimes causes slowly progressive cognitive impairment as the main symptom, and this may be fully reversible with treatment. Dementia is much less common under 65 years of age. Let us now understand what do we mean by Alzheimer's disease. Alzheimer's disease takes its name from Alois Alzheimer, a German neuropathologist. He first described it in 1907. Alzheimer is considered to be the most common cause for dementia. In DSM-4-TR, it is referred to as dementia of the Alzheimer's type. Alzheimer's disease usually has a slow and progressively deteriorating course, often leading to delirium and death. The awareness about this disorder increased tremendously ever since the late President of USA, Ronald Reagan, was diagnosed with Alzheimer's disease. Let us now understand the clinical picture of this disorder. Alzheimer's disease is diagnosed on the basis of thorough clinical assessment, but the confirmation is not absolute until after the patient's death. An autopsy must be performed in order to see amyloid plaques and neurofibrillary tangles that are distinctive signs of Alzheimer's neuropathology. Neuroimaging techniques are often used as a way to facilitate the early diagnostic assessment of the patients suspected to have Alzheimer's disease. But the ability of magnetic resonance imaging, that is MRI, to discriminate Alzheimer's disease from other dementia is uncertain. It is also difficult to diagnose the disorder as the MRI image seen in Alzheimer's is also seen in other disorders. For example, the increased size of the ventricles in the brain of a person with AD, Alzheimer's disease, is also seen in persons with schizophrenia, Huntington's disease and alcoholism. Alzheimer's disease mostly begins after about age of 45. It is characterized by multiple cognitive deficits rather than just a problem of memory. The clinical pictures can differ markedly from one person to another according to the nature and extent of brain degeneration. Alzheimer's disease begins with the person's gradual withdrawal from active engagement with life, lessening of mental alertness and adaptability, and a narrowing of social activities. Approximately half of the patients with Alzheimer's disease display a course of simple distortion and gradually start losing various mental capabilities. It damages the temporal lobes of the brain and delusions are found in some patients. Let us now understand the causes of Alzheimer's disease. It is basically caused by the death of brain cells. It is considered as a neurodegenerative disease, that is, which means that there is progressive brain cell death which occurs over a period of time. The size of the brain shrinks and the tissue has progressively fewer nerve cells and connections. This cannot be seen and tested in a living brain that is affected by the Alzheimer's disease. Autopsy will always show tiny inclusions in the nerve tissue called plaques and tangles. Having a certain gene, apolipoprotein E or APOE gene, put a person at a higher risk of Alzheimer's disease. Research has also linked traumatic brain injury with the risk of Alzheimer's disease. Now let us understand what are the treatment strategies. Basically, there is no known cure for Alzheimer's disease as the damage of the cell cannot be reversed. Even then, there are therapeutic interventions to help people live with Alzheimer's disease. Let us now understand what are these. First of all is drug therapy. Generally, no disease-modifying drugs available for Alzheimer's disease, but still there are some options that may reduce its symptoms and improves the quality of life. Some of those drugs are classified as characteristic inhibitors. These are donepezil, allotamine, rivastagamine and tacarine. A drug called memantine, an NMDA receptor antagonistic, is also used alone or in combination with cholinesterase inhibitors. Let us now know the other therapies. Psychosocial interventions are used as an adjunct to pharmaceutical treatment and can be classified within behavior, emotion, cognition, or stimulation-oriented approaches. The research on efficacy is unavailable and rarely specified to AD, focusing instead on dementia in general. The behavioral intervention attempts to identify and reduce the antecedents and the consequences of problem behaviors. This approach has not shown success in improving overall functioning, but can help to reduce some specific problem behaviors such as incontinence. There is a lack of high quality data on the effectiveness of these techniques in other behavioral problems such as wandering. The emotion-oriented interventions include reminiscence therapy, validation therapy, supportive psychotherapy, sensory integration, and stimulated presence therapy. Supportive psychotherapy has received little or no formal scientific study, but some clinicians find it useful in helping mildly impaired people adjust to their illness. Reminiscence therapy or RT involves the discussion of past experiences individually or in group, many sometimes with the aid of photographs, household items, music and sound recordings, or other familiar items from the past. Simulated presence therapy or SPT is based on attachment theories and involves playing a recording with voices of the closest relatives of the persons with Alzheimer's disease. The aim of the cognition-oriented approaches, which include reality orientation and cognitive retraining, is the reduction of cognitive deficits associated with AD. Reality orientation consists in the presentation of information about time, place, or person in order to ease the understanding of the person about his surroundings and the place in which he lives. On the other hand, cognitive retraining tries to improve impaired capacities by exercitation of mental abilities. Both have shown some efficacy, improving cognitive capacities, although in some studies these effects were transient, and negative effects such as frustration has also been reported. Stimulation-oriented treatments include art, music and pet therapies. It also includes other recreational activities. The main support for the use of stimulation therapy is the change in the person's routine. Let us now study the third therapy, that is the caregiving. Since Alzheimer's has no cure and gradually renders the person incapable of looking after himself, caregiving essentially must be carefully managed over the course of the disease. During the early and moderate stages, modifications in the living environment and lifestyle can increase the patient's safety and reduce the caretaker's burden. The modifications can include adherence to simplified routines, placing of safety locks, and labeling of household items. Patients may also become incapable of feeding themselves, so the food may be cut into smaller pieces or even pureed. When swallowing difficulties arise, feeding tubes may be required. In such cases, the medical efficacy and ethics of continuing feeding is important consideration of the caregivers and family members. The use of physical restraints, though rarely indicated, may sometimes become necessary to prevent harm to the person with AD or their caregivers. Careful management can prevent the occurrence of other medical diseases which occur in the process of aging. During the final stages of the disease, treatment is centered on relieving discomfort until death. Next comes dealing with caregivers. Taking care of the Alzheimer's disease is very stressful for the family members. For that, therapeutic interventions are introduced considering the situation of the caregivers. As caregivers also have a high risk for developing depression, so providing counseling and supportive therapy to caregivers is very beneficial and produces measurable reductions in their level of depression. Well, now let us understand what do we mean by vascular dementia. Vascular dementia is also known as multi-infarct dementia. It is usually confused with Alzheimer's as it has similar clinical pictures as of progressive dementia. It is entirely different disease in the context of its underlying neuropathology. In vascular dementia, series of circumscribed cerebral infarcts, interruptions of the blood supply to minute areas of the brain because of arterial disease, commonly known as small strokes, destroy neurons expanding the brain region. Now let us understand what are the causes of vascular dementia. Vascular dementia is less common than Alzheimer's disease, accounting for some 19% of dementia cases in community aged 65 years or older. Mood disorders are more common in vascular dementia than in Alzheimer's disease, maybe because subcortical areas of the brain are more affected. Vascular dementia has a shorter average course due to the patient's vulnerability of sudden death or cardiovascular disease. Sometimes some patients will be discovered to have both vascular dementia and Alzheimer's disease, a condition commonly referred to as mixed dementia. Now let us understand the treatment of vascular dementia. Treatment of vascular dementia is complicated but at the same time more helpful than Alzheimer's disease. Basic problem of cerebral arteriosclerosis can be medically managed to some extent, hence decrease the likelihood of further strokes. The other types of dementias are Lewy body dementia. It is characterized by presence of Lewy bodies in brainstem and neurocortex. It may cause visual hallucination, transient LOC, generally associated with Parkinson's or depression. The second kind of other types of dementia is frontotemporal dementia. In this, there is atrophy of frontotemporal region. There is a difficulty in differentiating from Alzheimer's disease, but things like memory and spatial awareness may be preserved longer. Often, there is a massive inhibition. Well students, now let us summarize what all we have learned today. Number 1, that age is a major risk factor in most of the neurodegenerative diseases like cognitive impairment, Alzheimer's disease, cerebrovascular disease and Parkinson's disease. Second, the term dementia implies serious loss of cognitive ability in a person's previously functional levels. The onset of dementia is usually gradual, with progressive deficits in abstract thinking, acquisition of new knowledge, motor control and problem solving. Third, sometimes dementia may be reversible, as in the case of B12 deficiency. However, dementia caused by aging usually has a poor prognosis and needs a different form of management. The symptoms must be present for at least 6 months for a diagnosis to be made. A common symptom of dementia is to deny that relatives and their even close family members are their own relatives. Causes of dementia depend upon the age at which the symptoms begin. In the elderly, a majority of dementia cases are caused by Alzheimer's disease, vascular dementia or both. Alzheimer's disease takes its name from Alois Alzheimer, a German neuropathologist who first described it in 1907. Although Alzheimer's disease is diagnosed after thorough clinical assessment, the confirmation is not absolute until after the patient's death. An autopsy must be performed in order to see the amyloid plaques and neurofibrillary tangles that are distinctive signs of Alzheimer's neuropathology. Neuroimaging techniques are often used to facilitate the early diagnostic assessment of patients suspected to have Alzheimer's disease. Next, there is no known cure for Alzheimer's disease, as the damage of cells cannot be reversed. Despite there are therapeutic interventions to help people live with Alzheimer's disease. These interventions include drug therapy, psychosocial interventions, behavioral interventions, emotive interventions and cognitive interventions. Next, since Alzheimer's has no cure and gradually renders the person incapable of looking after himself, caregiving essentially must be carefully managed over the course of the disease. Caring for the caregiver is also an important aspect of management, as caring for the persons with AD is highly stressful. Vascular dementia, also known as multi-infarct dementia, is usually confused with Alzheimer's, as it has similar clinical pictures as progressive dementia. Mood disorders are more common in vascular dementia than in Alzheimer's disease, which may be because of subcortical areas of the brain which are more affected. Vascular dementia is less common than Alzheimer's, accounting for about 19% of dementia cases in community aged 65 years or older. The treatment of vascular dementia is more complex, but at the same time has better prognosis compared to Alzheimer's disease. It is difficult to differentiate other types of dementia like Lewy body and frontotemporal dementia from Alzheimer's disease. Memory and spatial awareness may be preserved longer as compared to Alzheimer's disease.